We have changed the schedule, so you're presenting third. And we have Gruschen. Would you like to introduce Gruschen? Gruschen Veldtman, who is the next speaker of Fontan. Hi, Gruschen.
Hi, Michael. Can you?
So
okay?
What an extraordinary international session this is. Craig at 1 in the morning, me at 7 at night, and Gruschen somewhere in between. So Gruschen Veldtman's currently working in Riyadh in Saudi Arabia. He's one of the most prodigious researchers about heart failure and adult congenital heart disease and its impact for particularly the liver. And Gruschen, I'm sure everyone's very excited to hear your talk.
Thank you.
Michael and David, thank you very much for the kind introduction. And thank you for inviting me. I'm aware that there are people from literally from all four corners of the world joining us today, and I really want to wish them welcome. And I know that there's a spectrum of people from echocardiographers to exercise physiologists, palliative care people, and physicians joining us. So a very welcome, hearty welcome to you. I want to start with a really strange event that happened in 1854. And this was in the Black Sea during the time of the Crimean War, actually just at the beginning of the Crimean War. A series of meteorological events happened that really were quite devastating. And the first of these events was on the 5th of September, where there was a really dense fog. But that was not all. By the 14th of September, there were some raging storms with wind speeds of up to 120 kilometers an hour. And this caused absolute devastation, with 21 British ships being devastated, and also the premier battleship of the French, Henri IV, was completely destroyed, and multiple lives, of course, were lost. And if only we could prognosticate or predict that this event would have happened. Now, in the Fontan circulation, I think we all know that things usually go okay, at least as far as survival is concerned. And this is some data that my friend and colleague, Dr. Khalid Al-Najashi, has put together from the Prince Sultan Hospital here in Riyadh. And you can see that these results are absolutely excellent. In the modern era, at 5 to 10 years, survival is 97%. In somewhat earlier era, at 15 years, 93%. And like many other series in the very early surgical era, it is about, that should be 80% at 20 years. However, this is not the whole story, as David Celermajer and Yves Dudecombe have shown from the Australian and New Zealand database, that late adverse events really abound. And here at 12 years, 40% of patients will have late events. And at 20 years, almost 70% of patients will have late events. And we have some experience of what these meteoric events are in the Fontan. Amongst them, for example, severe ventricular dysfunction, severe AV valve regurgitation, just to name a few, liver dysfunction, hepatocellular carcinoma, thromboembolism, GI bleeds, and so on, a whole multitude of them. Well, the weather forecast and the weather forecasters are ahead of us in this game. After that event in 1854, the war minister de Saint-Arnaud, and forgive my pronunciation, appointed the most leading astronomer of the day, Urbain Le Verrier, to investigate whether it was possible to predict whether this weather event would happen, or could they have predicted that it would happen. And interestingly, he found that if he looked at the meteorological record, it was very evident 2 days in advance. The storm was actually coming from the northwest and going down to the southeast. And actually 2 days beforehand, they could have known had they done the homework beforehand. But this led to a whole host of scientific advances, and now the weather forecasters have a whole grid system across the globe. And not only a grid system across the globe, they also have an 80-kilometer height where they do various interrogations using this balloon radio sonde, for example, of humidity, temperature, precipitation, etc., etc. And based on this, they can predict what the weather is going to do in 15 minutes. That doesn't sound like very much. But what happens next, though, is very interesting, is that at 15 minutes, they now have a whole different cascade of things in this 80-kilometer height column of interrogation. They can then predict again 15 minutes in advance what it would be like. Then they predict 15 minutes again in advance once they've put all those factors into the 38 level grid, so that using that kind of a model, they can predict what will happen 24 hours, 48 hours in advance. Needless to say, for us in medicine, we've not quite gotten there yet. And actually, medical prognostication is quite a lost art, and we've really neglected it in the 20th century. Let me give you just some case examples very briefly. Here's a 25-year-old lady with double inlet left ventricle, normally related great vessels, and her VO2, peak VO2 is only 13 ml per kilo per minute. So what's going to happen to her? What's her prognosis like? Or here's a 40-year-old male with tricuspid atresia. He's got diastolic dysfunction, PLE, and heart failure. What's going to happen to him in the next 5 years? Here's a 16-year-old male with a complete AVSD and severe AV valve regurgitation and heart failure. What's going to happen with him over the next 5 years? And a 38-year-old female with unbalanced AVSD, a dominant right ventricle, and poor ventricular function, prior repair of her AV valve. What's going to happen to her? Well, actually, we do have some idea what the storms look like in Fontan. And here's some work that Tariq Al-Sayed and I did a few years back. And we looked at pooled mortalities in 6,700 patients. And here you can see what the causes of mortality are. So heart failure and Fontan failure, sudden death and arrhythmia, and Craig spoke about this in the systemic right ventricles already, but also respiratory failure, renal failure, thromboembolism, and so on, the usual culprits that we see. So there were 660 mortality events that Tariq documented. Clearly, this is too late. Once the storm has raged, it's too late. We've really missed the boat in this instance. I'd like to suggest that we should have a regular system of systematic interrogation that we can use possibly to prognosticate, maybe not 5 years in advance, maybe not 10 years in advance, but maybe in the next year, and then accumulate data in each of these fields. So here's some of these fields that we can have a look at. The pulmonary vascular reserve, cardiovascular reserve, which we all know a lot about, and have been multiple studies published in Fontan. The hemostatic system, atriopathy, and arrhythmia. And I'd like to emphasize, as Craig said, that arrhythmia is really the final point of a long process of disease, end organ disease. And I'd like to add to that nutritional status. Now, clearly, that's too much to cover in a talk like this. And I would really like to focus just on these three things, which is pulmonary vascular reserve, end organ responses, and nutritional status. So let's start. So here's a normal pulmonary vascular bed. And on the left panel, which you can see here, this is a normal arterial phase. Here's the capillary phase, and here's the pulmonary venous phase on the right-hand side. Now, this is some very nice work done by Susanna Mack from Toronto, and she published this a few years ago now. But you can see that the relationship between pulmonary artery pressure and cardiac output in normal individuals is really quite predictable. And here's a sort of normal curve, which should be less than 3 millimeters of mercury per liter per minute of rise in response to the cardiac output. And above that is clearly abnormal. Now, if we turn our attention to the pulmonary vascular bed in Fontan's, we know it's not normal. The intrauterine, there may be increased blood flow, obstructed blood flow, or severely diminished blood flow. But there's also differential pulmonary blood flow to different segments. Now, in the pre-Glenn phase, there may be native blood flow, which again may be increased or decreased. There may be segmental abnormalities. They may have an arteriopulmonary shunt. They may have collaterals. And this gives result to this segmental inhomogeneity of the pulmonary vascular bed. And this process continues post-Glenn and post-Fontan. And here the major culprits really are AV valve regurgitation, ventricular dysfunction, and diastolic dysfunction, which impact profoundly on the pulmonary vascular bed. But we also know that the biochemistry is important. And here's some work back from 1992, which just demonstrates how the pulmonary artery pressures rise in patients that don't have pulsatile flow. And here is pulsatile flow, this is non-pulsatile flow. As cardiac output increases, there's a profound rise in pulmonary artery pressures. Here's where there is pulsatile flow, and it doesn't rise to the same degree. And here's some interesting work from Germany, and you can see that this is a segmental area of the pulmonary vascular bed, and the researchers here looked at pulmonary flow reserve in different segments of the lungs, and this clearly is abnormal from lung segment to lung segment, or at least there's difference between lung segment to lung segment. And under normal circumstances, the relationship between resistance and compliance in the pulmonary vascular bed is also highly preserved. So the product of compliance and resistance is usually between about 0.1 and 0.2, as shown over here. But there's a disruption of this in the Fontan pulmonary vascular bed. Now, Alexander Egby also a couple of years demonstrated that there is actually quite a close relationship between what we measure in the central venous pressures or peripheral venous pressures and the pulmonary vascular resistance index. And this is really a poor man's way of measuring Fontan hemodynamics. And as you know, I've used this quite extensively, and we've used this in Cincinnati when I was there also quite extensively. Now, there is, from the literature, still a great need of work, load of work that needs to be done. But it does appear when the pulmonary vascular resistance is above 2 Wood units, that's when trouble happens, even in the Fontan circulation, or especially in the Fontan circulation, with abnormal microcirculation, lymphatics, end organ congestion, gut dysbiosis, and so on. And this is associated with greater Fontan complications, more mortality, transplantation, protein-losing enteropathy, and so on. So let's briefly turn to end organ responses. And I won't go into a lot of detail here because we've got a whole session on this later today. But just to say that as Fontan patients age, there's clearly an accumulation of end organ disease. And this is very, very clearly associated with mortality. Now, I'd like to just turn to nutritional status in the last segment of this talk. So in patients that have poor nutritional status, it's well recognized that immunity is compromised and response to acute infection is really very poor. I've personally seen this in my patients with protein-losing enteropathy. They do not cope well with infections. Myocardial function is decreased, there's loss of muscle mass, and there's also ultrastructural changes that changes the mechanics of ventricular function. The patients are also greatly susceptible to dehydration, and also their postoperative recovery may not be as good. And of course, mortality is increased. Now, just to define exactly what we mean by this, if there's more than 5% weight loss that's edema-free in the prior 2 months, that counts as a strong sign of cardiac cachexia. Or the BMI is less than 20 kilograms per meter squared. And usually there's loss of both mass, lean mass, fat, and bone. And this is accompanied by a raised CRP very often, interleukin-6. Hemoglobin is often depressed, and albumin and pre-albumin are depressed. So this is a patient of mine who is now had a Fontan some time ago, and she received it at the age of 3, and this is just her weight curve and a height curve on the right-hand panel. And you can see what's happening with her nutritional status. Absolutely worrisome. And this is because she developed protein-losing enteropathy at some point along here at the age of about 14 and 15, and clearly her growth was quite affected. She had multiple compression fractures of a spine, and you can see the osteopenia. And she had abnormalities in her albumin, pre-albumin, vitamin D, vitamin E, and so on. And also she was quite severely iron deficient when I met her. Now, these are not the only factors that are abnormal in nutrition. There's also B1, B2, B6, B12, and so on. And there's been some work to demonstrate that these factors actually may have direct effect on cardiac efficiency and cardiac function, and also that there's a tendency for these factors to be worse or reduced in heart failure. And supplementation may not be that difficult to achieve. So coming back then to our patients that we presented. So how can we, at least in the short term, predict what their outcome is? So this is the work that Tarek did, and I will finish up with this, which is that there's multiple factors we can look at. Pre-Fontan, that's really related to factors of underlying morphology and anatomy. And then in the post-operative factors, clearly, or perioperative factors, longer bypass, cross-clamp time, the usual culprits that we know about. And in the early post-op factors, I think you know many of these. Now, perhaps some of the factors that I really just want to point out is that it does seem that absolute VO2 on its own does not really help towards prognosticating mortality, but more towards hospitalization, unless it is very, very low. And I just want to show you also with imaging, this is some interesting work that Rahul Rathod is doing. And he's looking at MRI volumes. And in this data with Tarek Al-Sayed, which he hasn't published yet, indicating when the ventricular volume is more than 156 mils for the BSA, there's a much higher prevalence of mortality or transplantation in this group. And when you combine that with a worse global circumferential strain, that is even more noticeable. So 73% of patients will have mortality. So I'd like to finish up then and just say systematic data collection is important in the areas that I've shown you of pulmonary vascular reserve and also cardiovascular reserve and so on. And integrating data across large-scale data sets across the globe, multiple sites, and using this in a combined fashion, perhaps with artificial intelligence, might really help us to predict outcomes in the short term, which we can, exactly like in the weather system, then hopefully use that to predict outcomes in the longer term. So I'd like to finish and say life is short, our art is long, opportunity fleeting, experience treacherous, and our judgment is often difficult. And this is from Hippocrates' aphorisms. And with that, I'll thank you and close.
Thank you, Gruschen. What an amazing talk. I'll just point out that weather prediction might be much easier where you are than where me or Michael is. And so your insights have the clarity of someone who knows it's going to be 45 degrees and hot every day. Gruschen, many people will be more familiar with some of the material you presented about cardiac and end organ damage than they will about nutrition, which is a very exciting series of data that you presented. Do you want to say any words about weight as a reflector of nutrition alone? Because we and many others have found that just weight or BMI can be a little bit misleading in Fontans, where they have sarcopenia and edema and unusual distributions of fat and bone mass. Do you want to say a few words about how to interpret weight as a single variable in the Fontan?
Sure. Thanks, David, and really nice to see you and Michael. And I agree entirely about Riyadh has a great predictability about weather, by the way. It's 45 degrees most of the time in the summer. And well, I've grown accustomed to it. So with regard weight, I completely agree. I think it's one of the key observations that I've now seen repeatedly is if you look at patients though that end up in trouble, one of the things that stand out is almost all of them are really quite scrawny and thin. That's just, I think, a common observation. If I look at the last series of patients that have passed away, at least in my practice, they've all had that body habitus. However, I agree that maybe BMI is not the total answer. And one of my fellows, Matthias Posner, has done some interesting work using our routine liver screening MRIs and CTs to look at ileoceous mass also to help us. And we found that the ileoceous mass on CT and ultrasound really gives us quite a nice idea then of how much lean muscle mass loss these patients have. And in our experience, it is as much as 10% of a relatively well population. And what's interesting, David, is that there's a strong correlation, as you might expect, between exercise performance and this lean mass that gives us a little bit more of an idea of their nutritional status. But also what I would like to add, though, is that in patients that have low body mass index or have these phenomena, I think it's important to screen them for nutritional abnormalities. And we don't do that often enough. And once you screen them, you find a whole array of abnormalities. Now, obviously, a lot of work needs to be done as to whether we actually make a difference in treating those. But intuitively, you think that, well, if they're deficient, maybe, and that's causing, let's say, immune deficiency, maybe we can improve that by correcting some of this.
Thank you.
There's a question from one of our delegates, Gruschen. Thank you so much for being with us, and we keep you busy on this meeting. But it's from Pak Cho from Hong Kong, I think, who had spent some time with us. And what Pak is asking, should you be considering these patients for transplantation earlier? And I think this question pertains also to Greg's excellent talk. So maybe you would wish to comment, Gruschen, briefly.
Yes, absolutely. And I appreciate that comment. I agree that we should definitely consider these patients earlier for transplantation. The issue is knowing when to do that, though, because, for example, I looked after a patient that had PLE for 15 years, and the question is where along that pathway should you do the transplantation? That's one challenge, but I would like to postulate or hypothesize at least that if we have this regular systematic assessment of our Fontan patients, that maybe when there's major changes that happen along the way, we will have a clearer indication of when to transplant them. That's one issue. The second issue is donor availability. And, even with the best intent in the world, this is really, really challenging. And I found that in the US, in the United Kingdom, and here in Riyadh also, it's a real issue. So even though I might place my Fontan patient on the transplant wait list, this year I might find next year the patient is still on the wait list. And obviously there's patients that have higher acuity that take preference. And this honestly is the challenge. So I think though transplantation is probably the right way, we have to develop ways of looking after our patients prior to transplantation. And this is, in a sense, what this approach is about.
Thank you, Gruschen. And we may hear a bit more about it on the next session where you're discussing the liver. Maybe the liver is something to keep an eye on, will help us in that respect. We just need to move on, Gruschen. Fantastic.
Thank you very much.
Thank you. So I'm delighted to introduce